This next session is dealing with chronic illness, and we have two speakers. As I mentioned, Eliseo isn't going to be able to join us today, so I'll introduce them both now. Rudy Rodriguez is a physician and is director of hospital and specialty medicine at the VA Puget Sound Healthcare Systems and vice chair of the Department of Medicine at the University of Washington. He is a nephrologist and serves as the University of Washington Nephrology Fellowship Program Director. He is chair of a VA-wide Renal Field Advisory Committee, which is leading an effort to transform the renal programs within the VA, including education of providers and patients. His academic interests include health disparities, kidney disease among underserved populations, and increasing diversity in academic medicine. He is the University of Washington School of Medicine course director for the Hispanic Health and Healthcare Disparities course. He previously was a faculty member at UCSF and worked as a nephrologist at San Francisco General Hospital. So we're very fortunate to have him as one of our speakers. And the second speaker is Jenny McLaurin. Let me make sure I get her bio correct here. Sorry. I know Jenny on a personal level, but I want to make sure I introduce her correctly. Jenny is a specialist in child and migrant health, bioethics of Migrant Clinicians Network, with 30 years of experience in migrant community health. She is a board-certified pediatrician with a master in public health and bioethics and has worked at local, state, and national levels. Her career includes work as an outreach worker, physician, clinic medical director, state medical director of migrant health, and federal consultant and program planner for a variety of topics related to health disparities, social determinants of health, child health, cultural competency, and patient-centered medical homes. She has authored monographs and abstracts on migrant healthcare. Her teaching experience includes graduate-level programs and frequent lectures at the university in public settings. Dr. McLaurin worked in North Carolina for most of her clinical career, but has lived in Firdale, Washington for the past 12 years and works across the nation with the Migrant Clinicians Network and as a HRSA consultant. So we're very fortunate to have these two speakers this morning, and we'll start with Rudy.
There we go. Get all these things correct here. So thank you for that. The good thing about putting a talk together at the last minute is you don't have to worry about it for months like other people usually do. And after the conversations I think I heard yesterday, I decided to put this talk together using kind of end-stage renal disease as a kind of a model of talking about chronic illness. And also a little bit about what happens when you have a devastating illness like end-stage renal disease or cancer or, let's say, a horrible neurologic damage after an accident, what happens to an undocumented immigrant in this country. And I think dialysis is a nice way to talk about that. So, move this along. Use that. So, I don't know if many of you know this, but dialysis started, outpatient dialysis started here in Seattle. The first outpatient dialysis in 1960 in the world happened here in Seattle. And that had to do because Scribner, who was the first chief of medicine here at the University of Washington, created the Scribner shunt, which allowed dialysis to happen as an outpatient. And that was in 1960. So just celebrated the 50th anniversary recently. Soon after, this article was published in 1962, because this is where the death committee started also. because once dialysis started here, people had to decide who would actually receive dialysis. And they had these committees that were making these really controversial decisions based on whether people were married, whether they had kids, what their values were, whether they would get dialysis or whether they would die from kidney disease. And that led to 1972 when Medicare then decided to pay for dialysis basically for everyone in this country. And now Medicare basically pays for dialysis for everyone in this country except for very few people. So, I mean, even if you're in prison, if you murder someone, San Quentin has a dialysis unit. Prisoners of war get dialysis. About the only people in this country in some states that do not receive dialysis are undocumented immigrants. This is an article from the New York Times. Kevin Sack wrote a whole series about it when the dialysis unit in Atlanta closed, and patients either had to go home or receive what they called emergent dialysis, or they call it compassionate dialysis, which is kind of a misnomer, but I'll get back to that. Before I get to that, though, let me talk a little bit. So I'm going to give you two 15-minute talks, one on just end-stage renal disease, some chronic illness, and then I'll cover this very quickly about undocumented immigrants and ESRD, end-stage renal disease. So end-stage renal disease in this country is fairly rare, but basically this is from 1996. The rates to remember, this is for prevalence, is about 1,500 cases per million. Those are the dark areas here, and that was in 1996. In other words, in a city like Seattle, if there was 1 million people living here, you'd expect about 1,500 people on dialysis or transplanted or on peritoneal dialysis. 10 years later, these are all the areas where the rates are now up in the 1,500 per million. So it's really kind of blossomed. And that's why it's actually close to, I think, $15 billion of the Medicare budget. Actually, it's up to about 5% of the whole Medicare budget just to pay for dialysis in this country. That said, the big driver is diabetes. So I don't know if you've been hearing in the news this week, but this was published in the New England Journal of Medicine this week. And the story you hear is that from 1990 to now, there's been a decrease in myocardial infarction, stroke, and amputation among people with diabetes, although dialysis has been pretty level. And when you look, again, on why people are on dialysis, the majority it's due to diabetes. Second, it's hypertension. About 40% of people on dialysis, it's due to diabetes, another 30% due to hypertension. And this obviously changes the lives of people on dialysis. For one, they don't live very long. About 80% of people are dead after 5 years on dialysis. So the life expectancy is actually better for many cancers than it is for dialysis. And then kind of the racial differences are really dramatic with dialysis. So again, if you look at the rate per million, here's from 1981 to 2011. Here in this line is what you would expect on, this is incidence, how many new patients on dialysis you would expect. If you look at all racial groups, it's a little bit over 300 per million. If you look at African Americans, it's closer to 1,000 per million. In other words, if Seattle was just all African Americans, you would have over 1,000 new cases per year, compared to white patients down here, where it'd be less than 300 per million. If you look at Hispanics, it's about 500 per million, compared to non-Hispanics, where it's down to about 350 per million. These are new cases per year. This is a little busy, but one of the things you may say is that maybe it's all because of diabetes, a lot more diabetes in Latinos. But if you look here, this is actually then new cases of dialysis in patients with diabetes. This is Hispanics ages 50 to 59, 60 to 69. The average age of people on dialysis is 65. So this is really the line that you want to compare to. And you can see that the rates of new cases among people with diabetes is about a little bit under 1,500 per million, compared to white patients, which are down here, which is less than 500 per million, but it's high in African Americans, Native Americans, not as high as in Asians. So what are the reasons then that people may be ending up on dialysis? And diabetes is a big part of it. This is also was published yesterday. So again, the benefits of putting a talk together at the last minute is you put in new slides. But this just came in my mailbox yesterday. But so here you can see from up to 2010, this is the prevalence of obesity. And this is the changing prevalence of diabetes, which has been going up. Here in the dark area, people that don't know they have diabetes. So the message being diabetes is growing as obesity goes up. In this paper, they did look at Mexican Americans. And here in the blue, here in the greenish color, this is prevalence of diabetes. Here are the years. This is African American prevalence, diagnosed diabetes. Here's Mexican American, and here are white patients. What's worrisome is here in undiagnosed. This is white patients here, black patients here. Then you can see this year, in the last 5 years, as far as undiagnosed in Mexican Americans, it's actually the highest group here. And if you look at, in the same study, they looked at how well people are controlled. So hemoglobin A1C is below 7. And you can see, so this is better control. Whites had 57% had better controlled diabetes compared to blacks 52, and Mexican Americans 43%. And then, so this is the biggest cause, right, of end-stage renal disease, and this again feeds into why it may be happening at a higher rate among Hispanics, who are less likely to be controlled and have a higher incidence of diabetes. Hypertension being number 2, and this is a study that also recently published, but looked at hypertension. Mexican Americans actually have a lower rate of hypertension than whites and blacks. African Americans have a hypertension rate of about 40% in this country, and Mexican Americans are even lower than whites in the 20s. But if you look at then among people that have hypertension, Mexican Americans are less likely to be aware compared to whites and to African Americans, and less likely to be treated, 35.9% compared to 50% of blacks and 44% of white patients. So again, this is maybe what's contributing to this increased rate. A lot of people then say, well, maybe it's insurance status, and I always like to show this study from Kaiser, which looked at people with diabetes in Kaiser that obviously then had insurance. And this is 62,000 patients with diabetes, 10% of them Latino. So you can't really say that this is just because of insurance or not being covered. But a little strange in that if you look at myocardial infarction, blacks, Asians, Latinos compared to whites, they did better. Blacks, Asians, Latinos did better than whites in myocardial infarction rates, strokes, congestive heart failure, amputation, the same or better. But if you look at blacks, Asians, and Latinos, all had a higher risk of ending up on dialysis despite being covered in the Kaiser system. So there's questions that still remain, and this is a study of kind of the most important study in kidney disease that looked at the drug angiotensin receptor blockers or ACE inhibitors. This is a study that found that when you looked at the risk of dialysis, there is almost a 30% reduction with the use of this one drug over a 4-year period. So that's why it's such an important drug to use in these patients, in addition to treating diabetes and hypertension. But when they went back to look at some of the data, what they found is that they actually did have a really diverse group of patients. As you can see, 277 Hispanic patients. But they actually had the highest risk of ending up on dialysis compared to the other groups. So they actually, and then when they looked at whether they benefited from the drug, Hispanics actually didn't benefit from the drug. Although if they did respond to the drug by lower proteinuria, they did actually have a lower risk of ending up on dialysis. So a lot of questions we don't understand, I think, even with the drugs that we have in certain racial groups. this is a study I always like to show because this kind of shows you the progression of kidney disease, which is a 0 to 20-year history. When you develop glucose intolerance, here in the blue, it's kind of normal kidney function. People develop actually super normal kidney function when they develop diabetes, when they develop protein in the urine. But once they have a lot of protein in the urine, they lose about 10% of their kidney function and end up on dialysis 10 to 15 years later. And what I always try to remind people is that we get consulted over here, but really the difference is made over here when they're seeing primary care physicians way before when they're diagnosed with diabetes. That's when you really have to intervene. There's not much I can do once their kidneys are failing. So I don't have time to go over a lot of the research in this area, but the way I think of it is that there's all these factors that we know probably lead to the higher incidence among Latinos, being higher rates of diabetes, higher rates of protein in the urine, lower rates of treated hypertension, poverty, the lack of health insurance, health literacy, all these poor communication probably all lead to this devastating illness. Let me switch gears a little bit then to the undocumented question, right? So what if you end up on dialysis and you're undocumented in this country? If you live in Seattle or you live here in Washington, basically you actually are treated like any other patient, which is great. If you're in El Paso, Texas, it's different. And it might be good to hear from some of the people in the surrounding states because I know Oregon does not cover it. And so it would be good later to hear from some of the people in the crowd. What they're told in Texas is that they can't get chronic dialysis. They can't go to dialysis 3 days a week. What they'd have to do is wait until they're sick and then show up to the emergency room. They get a blood test to see if they can qualify for dialysis, if their potassium is high enough, if they're close to dying, and then they can come into the hospital and get dialysis. If not, they're told to go home. Some people come back, get dialyzed once a month. Some people twice a week, once a week, depending on how sick they are. They're told they maybe should think about going back to their home country or to move to another state. Here in the dark area are the areas with the most numbers of undocumented immigrants, about 2.5 million in California, 1.6 million in Texas. And I know in California, there are about 1,300 dialysis patients are undocumented, and it's about a cost of $50 million. So as far as why this happened and why it's different in all these states has to do with how emergency Medicaid is the interpretation. So I think probably in this crowd, a lot of you are very familiar with emergency Medicaid, which is basically coverage for Medicaid coverage for undocumented immigrants. And I skipped these slides about how the language of it, but basically it covers emergencies. And this is an important study from JAMA in North Carolina that kind of shows you who's covered. As you can see, 93% were Hispanic, most were young, 99.2% undocumented. Majority of people, the emergency that qualified them for emergency Medicaid was pregnancy. But if you look down here, North Carolina in 2004 spent $50 million. 8% of it was for dialysis, probably just for a small number of patients. Remember, dialysis cost about $50,000 per year per patient. So these are the states that currently do not offer, dialysis, including Oregon. Not sure about Alaska and some of the other states. But this is a huge issue, obviously, in Texas and also in Florida that has large numbers and in Georgia also. So the choices, I think, are in California, Washington, New York. The states do cover dialysis. Transplant is not covered. The only way some people have received transplants, but basically it's because they were able to raise enough funds to do it as an undocumented immigrant. Texas, they call it compassionate dialysis, which I'm not sure why they call it that, but that's what they call it. And that's, again, showing up to the emergency room and just getting this emergency care. Some safety net hospitals did have dialysis units, like Grady Hospital, but they closed it when they ran into financial trouble. And that's what led to them in the New York Times. And then other choices, again, are medical repatriation. This has become a big issue. I don't know if people have read this, have heard about this study that was published by Seton Hall Law School, but it talked about forced medical repatriation, where patients that are on dialysis or have had neurologic catastrophes are basically forcefully sent to other countries. It even was in the popular news with on the Colbert Report. He actually covered it. He called it the "I don't see you" or "I don't." The "I don't care" unit is what he called it, actually. And this is actually from I don't know if you've heard of MexCare, but it's a service that if you have an undocumented immigrant, you can call them, and they'll help you actually send your patient back to Mexico or to another Latin American country for a fee. And as you can see, they include dialysis, which is obviously very costly. You call them and you pay them a fee, and then they'll arrange for short-term dialysis at the home country. The question people ask, though, is what happens when you get to this country? So let's say in Mexico, obviously, they do have now Seguro Popular, which is a kind of a universal insurance, but it explicitly does not cover dialysis. So if you go back, you're obviously not going to have Seguro Social because you're not working, and basically you have to use kind of their public units. And this is what they've published, which is if you're uninsured or just have Seguro Popular, the rates for dialysis are about 230 per million, versus if you're insured, 1,200. In other words, most people do not receive dialysis and do not receive transplants. Guillermo Garcia, who's a nephrologist, this is his quote from the New York Times: "To have end-stage renal disease in Mexico is a tragedy. If you don't have Seguro Social, if you don't have private insurance, you're condemned to die." So repatriation for most patients is probably not a possibility. El Salvador is another place where a lot of undocumented immigrants are from. This is where my parents are from. I actually visited this unit in El Salvador a few years ago, and here they're putting in a temporary peritoneal dialysis catheter into a patient. In Central America, and you may be seeing these in some migrant farm workers, actually, that there is a new kidney disease that is being seen in farm workers in kind of the lowlands in Central America, not due to diabetes, not due to hypertension. It's thought to be something to do with either exposures. There's this whole theory that it has to do with kind of extreme dehydration, which I don't quite believe. But these patients are probably showing up here now. They actually don't even have enough units to kind of keep up with this workload. This is the new unit they've built, which looks nice. These are people receiving peritoneal dialysis. But this is what one of the physicians there told me, is that these are the people receiving kind of what's considered standard dialysis. Other people are coming in once a week, get a catheter placed in their belly, get about a day of dialysis, and they're sent home, versus kind of the accepted treatment, which is every day. They're getting about 40 or 50 new patients in this one hospital that they just can't treat. They're in the wards. So most of their hospitals is filled with people with dialysis. So in other words, sending these people back to their home country, there aren't really options. So getting back to then what's happening here, it's really all about politics. These are the red states, blue states. These are what we talked about yesterday, people not expanding to Medicaid. The map looking at who's covering dialysis in their states looks very similar. It's all about politics. This is a quote from the Medicaid chief, Georgia. The Georgia Medicaid program stopped paying for dialysis in 2006 amid rising sentiments in the legislature that illegal immigrants are a financial drain. He said Georgia and California and New York. And that's Mark Trail, the head of Georgia's Medicaid program. So these are the things that we talked about yesterday also, that the Affordable Care Act obviously will not provide treatment, will not provide any relief. We talked about how children are covered, but it's not helping that much. We talked about community health centers. I think something we didn't talk much about is safety net hospitals, because I think safety net hospitals like Harbor here, Harborview. I always want to call it Harbor UCLA. There's also, I went to medical school together. Or San Francisco General, they actually, that's where a lot of these patients can get some specialty care. But they really rely on these what's called DISH payments, or the disproportionate share funding. It's sometimes up to 20% of the funding for these hospitals comes from this funding. And the Affordable Care Act is giving back $18 billion of these payments away from safety net hospitals. It was announced that $1.1 billion will be taken away over the next year. So there's a big risk that even the safety net hospitals won't be there for some of these patients. So in the end, I think a lot of what we have to hope for is immigration reform. A couple last slides. I always like to remind physicians that the principle of patient welfare is that we're always just trying to do what's in the best interest of the patient. But it's just really hard to do that, I think, when we're dealing with a patient who has these incredibly high bills. We can't, I think physicians like in Texas, nephrologists, just are really anguished because they can't actually then provide dialysis. You can't just do that for free. So there's no kind of ready solution. What I have pushed when I've given this talk to nephrologists is that we have to kind of speak up in a louder voice, and kind of our own professional societies don't like talking about undocumented immigrants. During an interview I was giving for a newspaper, the reporter told me that she had called, for example, the Transplant Society trying to get a statement, and they said they didn't want to say anything because it was just bad for their brand. Somehow they thought that they just couldn't talk up about it. So people feel like they'll get into trouble or something if they talk about undocumented immigrants. But I think we all need to really care about this issue. So I just wanted to end there and turn it over to our next speaker.